Hello, my name is Jay Huang. I'm a junior attending in the United States. I go over cases almost on the daily from head to toe. Today we're going to go over Johns Hopkins Surgical Pathology Unknown Conference. This is week 812, case 3. Shout out to Dr. Marissa White and Dr. Samuel Law for this case. This is an adult female with a skin nodule. Select the correct diagnosis. So what we see here from low power is some acanthosis, a little bit of papillomatosis, pseudohorn cyst, which is invagination of the stratum corneum. And we see a little bit of reticulations where it kind of looks like net-like. So we see those pseudohorn cysts again. And we see in the reticular dermis relatively unremarkable collagen. Here we have a closer up of the reticular dermis. So there is a little bit of like collagen trapping, although I don't think this is a dermatofibroma. But we have some cells that could be lymphocytes, that could be something else kind of percolating through the reticular dermis. Here is a closer up view of these cells that are single filing. One might think that this might be eccrine glands, but I don't see any lumen, and I just see single filing of cells. So this is concerning for carcinoma, a metastatic carcinoma. These cells are bland, and they don't elicit a desmoplastic response. So the diagnosis, what is it? I don't think it's melanoma because I didn't see a lot of pigment. I don't think it's gastrointestinal signet ring cell carcinoma because there was no mucin vacuoles, no signet ring cells. Seborrheic keratosis, yes, on the epithelium with the pseudohorn cyst, but it's probably invasive lobular carcinoma and seborrheic keratosis with the infiltrative single back-to-back cells without a desmoplastic response. So let's see. So yes, histologic sections are comprised of pseudohorn cysts and epithelial hyperplasia at the surface of the nodule, which are reminiscent of SEB-K. However, deeper to the SEB-K, there's a hyperchromatic invasive linear cell population that percolates through collagen bundles into the subcutaneous fat. The nuclei appear plasmacytoid, and the cells have amphiphilic cytoplasm. The patient had a history of breast cancer, and the findings are most consistent with invasive lobular carcinoma involving a seborrheic keratosis. Invasive lobular carcinoma may be extremely bland on low power, and thus recognition of patient history as well as an IHC workup, usually cytokeratins and hormonal markers, ER and PR, may be useful. On medium to high magnification, the cells appear to percolate in linear formation like a soldier's march, and the cells may be discohesive and plasmacytoid. Melanoma, especially the desmoplastic subtype, may be subtle on low power, just like invasive lobular carcinoma. However, desmoplastic melanoma subtype stains for SOX10 and S100, and interestingly is negative for melon A and HMB45. This is suggestive of the theory that a desmoplastic melanoma is a subtype that shows differentiation towards a more neural-like phenotype. Other subtypes of melanoma, lenticular maligna among others, will be positive for not only SOX10 and S100, but HMB45 and melon A. Gastrointestinal signet ring cell carcinoma may be notoriously difficult to detect, and the index of suspicion for a metastatic signet ring cell carcinoma is high in a patient with this cancer as their known primary. To make matters complicated, some forms of invasive lobular carcinoma may demonstrate a signet ring-like morphology. IHC stains that may be helpful include CDX2 to rule in signet ring cell carcinoma, and ER-PR GATA3 and mammoglobin to rule out invasive lobular carcinoma. Well, thank you very much to the Johns Hopkins Surgical Pathology Unknown Conference case, and I will see y'all next time. Bye.